I got one favorite story I've got to tell you if I haven't told you before. And that is, a woman came into my office with her husband, and she said, my problem with this man, he doesn't give me enough sex. I said, why not? My internist says, if I have too much sex, it'll kill me. So she said, so what? Well, what do you think happened? He was dead a few weeks later.
Deborah and I thank you and Mrs. Spotniz for the opportunity to be here today to discuss modern group psychoanalysis.
I want to welcome Dr. Charles Bichavsky, and I want to welcome Deborah Bichavsky. It's a pleasure to see you here now, and it's a pleasure to work with both of you on modern group psychoanalysis.
Speaking of modern group psychoanalysis, what made you be interested in what is modern group psychoanalysis?
Modern group psychoanalysis is a way of treating a group of patients so that they'll get over their schizophrenia. We're treating schizophrenia. We're not interested in any other results. The other results are byproducts of curing schizophrenia.
So originally it was developed to work with schizophrenics.
Exactly.
I see.
I went into the field of psychoanalysis because I was interested in curing schizophrenia. I had two primary interests. One was cancer, and the other was schizophrenia. I worked with schizophrenic patients, and I worked with cancer patients, and I've cured both. And it's very difficult to believe it, because most people don't want to believe it. When I cure the schizophrenic patient, they say they were never schizophrenic. And when I cure the cancer patient, they say it was a spontaneous cure. The only way to convince people that modern psychoanalysis cures patients is to get the therapist to do it. That's the purpose of modern psychoanalysis, to convince the public that they can be cured through analysis.
Can you tell us how you first became interested in treating schizophrenics in groups rather than individually?
I was a consulting psychiatrist at the Jewish Board of Guardians, and there I was consulted by Sam Slavson on group therapy. So when we tried group therapy on the schizophrenic patient, it worked. They got better too. Schizophrenic patients get better when you apply modern psychoanalytic principles to the group and to the individual.
When you first wrote about groups and your work with groups, you identified two issues that you considered to be major issues in working with groups. One of them was the phenomenon of group resistance, and the other one was the problem of what you called the induced neurosis in the analyst. Could you talk a little bit about those two things?
Well, the purpose of putting people into groups is to treat several people at once. And when you treat several people at once, they all have individual resistances.
Right.
If you resolve the individual resistances, then you encounter a group resistance. And the group resistance is what everybody is doing at the same time. So that's the group resistance. When you cure the group resistance, you cure the whole group at once. When the patient gets to have different kinds of feelings in the group, especially in the group, if they have group feelings, they all feel the same way. They induce feelings in the analyst. That's the induced neurosis. And the induced neurosis becomes a countertransference resistance, and then you have to analyze the countertransference resistance in order to be able to cure the patient. You'll find in the people that you described that the group therapists get certain feelings that the patient induces in them, and then they can't treat the patient. unless the induced neurosis is treated by the supervisor.
It must be very difficult on the group leader.
It's impossible for the group leader. The group leader gets destroyed by the group. A group analyst has to stop working with the group because the feelings are too strong. Can't work with them. It's very dangerous to treat a group of schizophrenic patients without a supervisor.
It's like you can download those feelings onto the supervisor. You don't have to walk around with them.
That's right. Very good.
And hopefully not drive the supervisor crazy.
Well, the supervisor can consult his own analyst. You need an analyst, and you need a supervisee, and you need a whole team.
Also, in your early writings about group, you said that you found that drive theory alone was inadequate to deal with the forces operating in human interactions. And so you came up with the concept of two constellations, the reproductive constellation and the inadequacy constellation of forces. Could you explain those a little bit?
When you start to work with groups, you discover that they have a lot of emotions in the group.
Yeah.
And if you study the emotions they're talking about, there are three types of emotions in the group. They feel inadequate. The second one that's the inadequate constellation. There's a reproductive constellation where they all want to have sex together and make babies. And then the third constellation of forces is the negative reproductive constellation. That is the one that Hitler used to perfection. He killed millions of people by using the negative constellation of force. Those emotions were used to drive Nazi Germany to kill millions of people. When you get a group of people together, they show all three: inadequacy, reproductive, and negative reproductive. And that's a very dangerous group of forces. And the classic example of that was I discovered it with adolescent group. But you'll see what happened in Colorado. All these people there were very negative. They developed very negative forces, and they were out to kill everybody, including themselves. And they were operating according to Hitler's birthday, because Hitler really was exquisite in killing everybody. He wanted to kill everybody, including himself. And he was a great success.
So when you begin to encounter the negative reproductive constellation of forces in the group, you have to be ready to intervene properly.
You have to be ready to find yourself out to murder everybody, including the members in the group.
And when you get that feeling to murder everybody, then what do?
You go to your supervisor.
And you say, oh, I have the feeling to murder everybody in my group.
What do I do about it?
Right.
And the supervisor tells you what to do. If the supervisor doesn't know, he consults another supervisor until they know what to do.
So what was missing with the drive theory? Why was the drive theory inadequate?
The drive theory was not inadequate as far as I was concerned. I'm very satisfied with all the theories.
With all the theories?
I like all theories. I just found that using the positive and negative reproductive constellation force and the inadequacy made it easy to understand what they were talking about. It facilitated understanding. It didn't necessarily make you a better therapist unless you find those ideas very compatible. But I'm very much in favor of every theory. I don't reject theories unless they don't work. If they work, I use the drive theory, the reproductive theory. I use them all.
You use whatever you need to use
to cure the pain.
Understand and get people to say everything.
That's right. I don't reject theories. I just say, this theory didn't work with this patient, that's all. It worked with another patient, it did. I mean, I went to Nuremberg for supervision. He'd tell me what to do with the patient. I tried on the patient, he said it wouldn't work at all. So I tried another patient. It worked perfectly. The same intervention may be good with one patient and not with another one.
Can you get better understanding in individual treatment if you look at the forces operating through the lens of these constellations?
I find it much easier to understand the patient when you look in terms of the negative reproductive with schizophrenia. That's classical. The schizophrenic patient is dominated by the negative reproductive constellation of forces. They're out to kill. If you can help them master their impulse to kill, you have no trouble curing them. If you don't help them master the impulse to kill, you can't cure them. They go and throw people on the subway trains, they stab them, they murder them. The defense against the murder is not working. That's the big danger with schizophrenia, that they have overwhelming impulses to murder.
What changes and techniques have you used over time?
When I started out working with a schizophrenic patient, I used to be a nice, sweet, loving guy. I didn't cure anybody. Then when I started out to be a mean, vicious bastard, then they became vicious and mean bastards to me. They started to get better. So I found out that you've got to deal with the negative forces. You've got to help the patient feel all his murderous feelings, but in proper dosage. If they get too much murder in them, they kill you and themselves. So you've got to be very careful how you deal with the murderous potential in the schizophrenic patient. I have used the joining techniques.
Joining technique.
Joining technique. I treat the patient the way he treats me. I imitate the patient. So the patient finds in me a reflection of himself. And he says, this bastard can live, I can live too. If he hasn't killed me, I don't have to kill him. They get to accept the idea that you and I are alike and we don't have to kill each other.
When you work with individual patients, you work on developing a narcissistic transference.
Right.
How do you do that in group?
I group the same way. You don't say anything. You only ask object-oriented questions. You don't try to change the patient in any way. You just help the patient be himself, and you ask object-oriented questions, and the patient senses you're not trying to change him. If you're not trying to change him, he's fine with you. What he's afraid of is when you try to change him, he'll kill you or kill himself.
But then the members of the group start to try to change one another.
When you're leading a group of schizophrenic patients, you ask object-oriented questions. You don't help them change each other.
So if you observe them trying to change each other, you by asking object-oriented questions, you interfere with that.
That's right. You don't let them change each other. They want each other changed. That's too dangerous. Unless they learn, if they come on time and pay on time and act normally, then you can start to change them, if they have control. But if they don't have any self-control and you change them, they're liable to kill everybody. You don't try to change a schizophrenic patient until he's well controlled.
Until he wants to change.
Which takes 5 to 10 years.
Who do you put in group, Dr. Spotniz, and when?
When I'm treating groups, I put everybody in the group. Everybody.
Most certainly do.
And I have no objection to treating anybody in the group. I just make sure that who's being treated in the group is not being damaged. If they're being damaged, I either break up the group or get them out of the group. I don't maintain a group that's damaging anybody. You can't stop it. You got to tell them to leave the group or you break up the group. The group is supposed to be a constructive therapeutic force. If it's operating destructively toward anybody, they don't belong in the group, and the group should cease to exist.
Now, getting back to the inadequacy constellation, when you see that operating, how do you intervene?
I don't intervene at all. If they're inadequate, let them say everything. If a girl says, I'm not equal to getting married. I'm not equal to having children. You ask them object-oriented questions. What man did you ever want to marry? If you got married, how many children would you want to have? Yeah, but you ask questions that are primarily object-oriented, not ego-oriented. When they're inadequate, and you don't try to make them adequate until they're ready to become adequate.
Right. You accept them.
If they ask that they want to become adequate, then you ask them, how can I do it? Object-oriented question. How do I make you adequate? What intervention should I make? It's safe to make interventions that they recommend. It's not safe to make interventions that you want to make if you don't know the effects of the intervention.
So it's always good to consult the patient.
You consult the patient on yourself. That's object-oriented interventions.
In recent years, you've spoken a lot about the analytic countertransference that develops in the analyst. These are feelings that the analyst develops toward the patient that the patient never had. And I was wondering if you saw an equivalent in groups that develops over time.
Yes, I have written on it yet, but it does happen in groups too. If you work with a group of people over a period of time, you get to have feelings for the people in the group. If these feelings are feelings they didn't have with their mother or father or anybody else, these are new feelings that you're developing. That's what I mean by the analytic countertransference. You feel what the patient needs to feel to get well. You say, if I did have that feeling, what would happen? If you communicate it, you're endangering the patient. They get too stimulated.
We're talking about people in group. Now, you do something many therapists wouldn't do. You put married couples in group. You put patients with their analysts in group. You put relatives in
on a trial basis. If it works, they can stay in the group. If it doesn't work, they have to leave, or the group breaks up. I don't permit a group to exist if it's destructive. And only groups can exist if they're constructive. If I see they're being destructive, I want to stop the group. We're stopping this group. I'm not going to work with a group that's willing to have me be destructive. I'll admit anybody to any group on a trial basis. If the trial basis is destructive, the group is eliminated or the individual is eliminated. I always try to put the blame for whatever I do on myself. I'm ruining the group. Therefore, they shouldn't work with me. What's very important in working with the group is to stay object-oriented and to talk about yourself. You talk about some subject that's not ego-oriented. You take the subject off the patient.
Right.
Yeah, you talk about, you say, what about, have you ever heard Deborah Vishevsky? What do you think of her? If they talk about that, calms things down. Become an egomaniac. If you're an egomaniac with a group, they say, you sound very narcissistic, Dr. Spotniz. You seem very interested in yourself all the time. What's wrong with that? What's wrong with me? Why shouldn't I be self-interested? Then they attack me. That cures schizophrenia.
How do you develop a contract in the group?
First, you have to have people who aren't in a group. Then you ask them if they want to join the group. A lot of people come and want to join the group, or they've been in the group and they want to go to another group. So what you do is you say, you want to join a group? They say yes. Discuss with them what kind of group they want and how it would work. And then I analyze why they want that type of a group and why they think it'll work. If they all agree on what type of a group they want, that's the contract.
So it seems
I analyze resistances to being a group.
It seems that you ask questions.
I ask a lot of object-oriented questions.
The contract comes out of the questions.
The contract comes out of the analysis of the resistance to the contract. I know what the contract is going to be. Monday at 2 o'clock. That's the contract. How about you people coming at that time? No, it's no good. And what other time do you like? We discuss it over and over again. Eventually, I analyze the resistance to their meeting at Monday at 2 o'clock. If the resistance is resolved, they come Monday at 2 o'clock.
After that, you move on to what they're supposed to do when they come Monday at 2 o'clock.
Exactly. They're supposed to talk.
Do you get them to say everything in group?
Yes, certainly. That's the goal, to say everything. And they say, I don't want to say this. Yeah, eventually, if you want to get cured, you've got to say everything in the group.
Well, what if saying everything in the group for one patient means damaging another patient?
If the patient can't accept what he says, they don't belong in the group. I discuss it. Who should leave? If you're hurting each other, you don't belong in the group together. One of you has to leave.
There's a network of transferences that develops in the group amongst the members. How do you utilize that network of transferences?
If patients have transference to each other, I have no objection to have transference, and I have no objection to their saying everything. So if they say everything, they are getting cured. If danger exists, I discuss what should be done. If this is a dangerous group for you, or for him, or for the group, what do we do about it? If the group should break up, if one should leave, if two should leave, we discuss it.
What about the contract of being in the moment and saying your thoughts and feelings towards the other group members and why?
They're supposed to say everything. And so they don't have to say anything to the other group members or to each other. When I work with a group, I help them deal with the individual resistances first. When they talk about their individual problems with each other, and then they become a group, and they have a group resistance. And the group resistance really usually takes the form that they want to kill me off. They want to break up the group. They don't want the group to exist. So then I analyze, what did I do to create this situation? What's wrong with me that this group wants to kill me rather than love me? Then I have to decide whether I want to work with them or not. How dangerous is it?
In the group setting, is it okay to work with individuals?
That's called dealing with individual resistance in the group.
So that's what you were saying.
Yeah, there's no reason why I can't do it. You can use any intervention you want as long as it's therapeutic.
Many students ask this. Then what happens when you cure the narcissistic defense?
You get the object transference.
Right, but they worry, how do you know that you're not going to cause murder if you resolve?
If you don't know, you would get rid of the patient. If you think you may be causing murder, you discharge the patient.
Well, the patient is no more attacking themselves. Now the aggression is going to be focused outside of themselves.
Right.
So
if there's any danger of their acting on it,
exactly,
then they have to leave.
So one way of dealing with acting out patients is to say, if you continue this, you have to leave. Isn't
right.
that it?
You don't belong in this group. You belong in a group where you can control your behavior.
What's the most dangerous resistance in a group?
Where they want to kill each other. I had 5.5 years of analysis 6 days a week. I was analyzed. My analyst, Dr. Lillian Delga Powers, was analyzed by Freud for 5 days a week for 6 months. Then he discharged her, and then she came here, became a vice president of the New York Psychoanalytic Society. When I came to the New York Psychoanalytic Society and wanted to be analyzed so I could cure schizophrenia, they wanted to have nothing to do with me. So I went to Dr. Powers, and she said, oh, I'll work with you. I'll work with you. I'm not worried about it. I would probably still with her if my wife hadn't told me, you've had enough analysis. But she was wonderful, because all the interventions that I use with schizophrenic patients if I didn't know them myself, she taught them to me. And she was very positive toward me, and she said they should accept me in the New York Psychoanalytic. But they wanted to have nothing to do with me if I wanted to treat schizophrenia. Freud said it couldn't be done. But I said I already did it. The diagnosis was wrong.
Of course.
The wrong diagnosis. If I cured the patient, she was a spontaneous case, not schizophrenic. Anybody who I treated who was cured, the diagnosis was always wrong. They had no use for my cure of schizophrenia. I told you, that's why we formed all the Modern Psychoanalytic Institute, to cure the schizophrenic patients that the classical analysts said can't be cured. And now there's one modification. They say certain gifted therapists can cure schizophrenia. That's the last 5 years. They've been saying that now.
What about the fact that schizophrenia is now considered to be an organic brain disorder?
Well, look, when you're born, you have an organic brain disorder when it comes to talking French, right? You can't talk French.
Right.
If you're taking the good instruction, then you can learn to talk French. The same with schizophrenia. When you're born, you don't know how to be a normal person. So you need training on how to be a normal person. And all my schizophrenic patients, I tell them, if you want to be a success in life, you got to take courses on how to be normal. Any crazy ideas you have in your head, keep it to yourself. Don't tell anybody.
So it doesn't matter how the patient feels, only how the patient acts.
That's it. Only what they act. If they act normal, they're normal. If they act to kill people, stab people, they're schizophrenic.
Speaking of murder, how do you destroy a group?
Very simple. You must be loving to each other. Just say loving. In this group, you can only say loving things to each other. They'll kill everybody. And they'll tell you how to do it, too. But if you tell them this is a group where you may be trained to murder, you got a chance with schizophrenic. But if you say, you people got to be loving to each other, that's involves they're killing each other.
Can you tell us about the use of the Toxoid response in the group?
The Toxoid response is you use the intervention that the patient used when he first came to the group. I had a patient who was always being attacked. And when he was being attacked, he submitted and fell apart. And so, well, after I treated him with him, and he knew how to deal with that attack on himself, then I tested him out by giving him the Toxoid response. I treated him the way people used to treat him.
How does the group enhance the mental health of the analyst?
Well, that's easy. The analyst gets to feel all the feelings of the patient. And if he analyzes his reaction to those feelings, he becomes cured. Whatever the emotional illness the patient has, if these feelings are induced in the analyst, and the analyst analyzes them so he doesn't have to act on them, you've cured yourself. And if you can't do it yourself, you go to your individual analyst who'll cure it. I know with my analyst, when I work with patients who induce terrible feelings, she would help me with my feelings. Help me with the feelings, and I would help the patients. So I was cured of all the schizophrenic all the schizophrenic feelings that all my patients had. Every schizophrenic patient I had, Dr. Powers would cure it in me first.
What happened after you stopped working with Dr. Powers and you were working with all these patients and working with so many groups. How did you?
I used the patients that I cured or partially cured to analyze me.
I see.
I would consult patients. I said, I have a patient. Do you mind if I discuss? I would say to them, do you mind if I discuss one of my difficult patients? And he's doing this and this to me. What do you recommend I do? They would make interventions.
I see.
They would recommend how I treat the schizophrenic patient that I'm having trouble with. If A didn't do it, I went to B or C. I consulted all my patients till I found one that gave me the right intervention. If I couldn't find any, I sent the patient to somebody else. If I could cure him, I did it with the help of all my patients.
How is the group potentially damaging to the mental health of the analyst?
Oh, if you don't let yourself feel everything and say everything to yourself, that's very dangerous.
I see.
If you don't want to feel something, you repress it, and you get psychosomatic illness. You can get cancer or any other illness.
So all the feelings have to be processed.
All the feelings have to be verbalized and understood. If you bury certain feelings as an analyst, you're endangering your life.
What's the most difficult situation you ever encountered in a group?
When they all want to kill me.
Which sooner or later happens in every group, right?
I tell them I have to get out. Either they have to stop wanting to kill me,
or leave.
Or they have to leave. I'm not going to let them stay there and kill me. They got to behave themselves. They got to be in control and behave properly if they want to kill me.
Is there a necessary amount of object relatedness that a patient has to have to be able to function in a group?
No. Depends on the skill of the analyst. If you have the skill, you can treat any patient in the group. If you can't do it, put them in the trial basis. If you can't treat them, discharge them. Don't treat any patient in a group who you feel you can't treat. I've treated many untreatable patients. I found them treatable. There's one patient that I found untreatable. I'll never forget her. I treated her for 20 years. When she first came into my office, she jumped up and punched the door. 20 years later, I made an intervention, and she jumped up and punched the door. I said to her, if after 20 years you still have the same symptom, I couldn't cure her. And so she said to me, you're no good for me, I gotta leave you. I told her we agree. So she left me, and she died of cancer a few years later.
Do you have any recommendations to group analysts and students?
Yes. Have a good analyst yourself. If your own analyst is no good, get another one. I had one patient come to me once, and she said, I went to this world-famous analyst. I left him. He didn't help me. I went to this other guy. Everyone tells me he's a shyster. He's helping me. Think I ought to leave him and go to the other analyst? I said, nothing to him. Stay with the shyster.
Stay with the shyster.
And get well.
Didn't you have a patient that was cured without ever being seen?
Yes. On a Thursday night, a friend of mine called me up and said they has a relative who's dying. She had been vomiting. I came over Friday night. Everybody was singing and dancing and drinking, all happy. He said, what's the matter here? He said, well, the patient that we told you was dying is all better. They said, we told her a psychiatrist was coming over to see her, and she stopped vomiting. And I said to her, tell me what happened. You were vomiting and you were dying, and now you're all better. He said, Dr. Spotniz, I'll tell you the truth. I'm terribly afraid of psychiatrists. And when they told me a psychiatrist was coming over to see me, I said, Sadie, stop vomiting. And she said, I'm not going to vomit anymore if you're going to bring a psychiatrist. And so I said, you want to come to my office? I want to have nothing to do with you, Dr. Spotniz. Stay far away from me as you can. A couple of years later, she was a little nauseous. They asked her, do you want to see Dr. Spotniz? She said, oh, no, I'm not nauseous. I once had a patient whom I treated for several years, and he's always telling me I didn't make the right intervention. Whatever I said was wrong. At the American Group Therapy Association, he joined one of the big groups, and I was conducting the group. And one group member said something. I don't remember what she said, but she said, "Dr. Spotniz, I've been trying to get you to say that for years." I said, "What was it?" I said, "I've said that, but you didn't say it with the right tone of voice." But now after she said it, I'm all better. And that symptom went away. The patient, another group member, said something in the right tone of voice that cured him of that symptom.
Deborah and I thank you very, very much for having us in your home, and for the students and faculty at the Mid-Manhattan Institute for having this discussion.
Thank you very much for making it possible and for coming here and asking me the most entertaining questions. I found them delightful.